So the problem with AFib is the atria are not beating. They're fibrillating, like a bowl of jello. And so the ventricles are still beating just fine, but the atria are not. So the problem with blood, when it pools, is it clots. And so that's the big problem with AFib, is we've got potential clots in here. And so what would happen if one of those clots broke loose?
Stroke.
Yeah, it could land anywhere. And I've seen them land in crazy places. If the clot's in the right atria, it's going to shoot out into the lungs. Now you've got a pulmonary embolus. If the clot is in the left side, it's going to shoot out into the aorta. Your aorta branches like this, but right off of there is the main artery that feeds your brain. And so something like 80% of the clots that shoot out on the left side shoot straight up, and that's the leading cause of strokes, AFib. So how might we prevent that? And so definitely no Coumadin, but for testing purposes, but do know that for the most part we're using Eliquis and those newer blood thinners. They seem to be you might have seen those commercials. They do seem to be a little safer than Coumadin, Eliquis. So we worry about stroke. I had a lady who threw a clot and it landed in her left bicep, in that artery there. So she came in just screaming in pain because her left arm was completely white and turning necrotic. No blood supply whatsoever to her entire left arm. I took care of another patient. Actually, this is a fairly common problem. It shoots down and infarcts the mesenteric artery, which kills off part of your bowels. So you could shower a clot and it could land anywhere. If it lands in the renal arteries, you just shut your kidneys down. But 80% of the time, we're just talking about a stroke. And then we'll talk this afternoon what AFib actually looks like on the monitor. I was hoping that monitor would be working, but. So up here, maybe I'll turn this drawing into a person. This is the artery feeding the brain. This is his shoulders, arms.
That's a lot.
He has a little head because I ran out of space. I should draw it there on the. So when we're talking hemodynamics, we're going to primarily be talking about shock, and what is shock? There's different types of shock, but what really is shock?
Impaired tissue perfusion and oxygenation.
Exactly. So shock is simply perfusion. So remember that word. We have a tissue perfusion problem. And it's vitally important to know the difference between blood pressure. When we measure blood pressure, we inflate the little blood pressure cuff, and we're measuring the pressure in the blood vessel, right? That's blood pressure. And as nurses, we get very hung up on this one thing. Blood pressure doesn't really matter. What really matters is blood flow. Because we can have all the pressure in the world and no flow. As an example, if this was a cross section when we are trying to manage blood pressure, we will start a medication called dopamine, which clamps down the blood vessel, causes vasoconstriction. The reason we're doing that is to try to increase blood pressure. But if your artery is now this big around, because you started dopamine, what happened to flow? So let's talk about clickbait and why I don't do social media. Everybody's an idiot. Do you guys remember seeing this on Facebook? This last year?
Yes. Oh my gosh. He was like dead. It wasn't like someone else.
It might be this guy.
Okay. There's not two guys that had the dogs.
So a man who lost his limbs after a dog licked him, a friend's dog licked him. That's all. And then look what happened to him. He lost all 4 extremities and most of his nose. So what the media response was, and social media and Facebook and everybody's literally getting rid of their dogs. Because what? I could have that happen if my dog licks me? Well, what had really happened is he got septic. He got septic. And sepsis can be caused by anything. So a dog lick, sure, there's bacteria in a dog's tongue, and that's what, in his case, they cultured out of his bloodstream, was a bacteria specific to dogs. Telemarketer. But it could be any bacteria imaginable that causes the septic shock. The real problem here was not the septic shock. The real problem was the nurses and doctors getting confused about pressure, blood pressure versus blood flow. Because we can start dopamine, it's a very gentle vasoconstrictor, or we can jump up, let me draw these to scale, we can jump up to the next most potent vasoconstrictor, and that is what that's called?
Norepinephrine?
Norepinephrine, exactly. So now your blood vessels are quite a bit more constricted. Or, let's say our blood pressure is still crap, we're going to jump up to the next stronger one.
Vasopressin.
Well, epinephrine, but vasopressin is often substituted, so that's great. But if you notice, what's the circumference of this blood vessel now? Is he getting any blood flow?
No.
We've got great pressure. If we're just taking that blood pressure, it's like, man, he's got great pressure because this blood vessel is now this tiny. Great pressure, no flow. And remember, shock is a problem with tissue perfusion. And so what I'm guessing happened in the dog lick incident is that hospital did not follow the sepsis protocol, which is not surprising because half of hospitals don't follow the surviving sepsis guidelines. And so I'll go back a slide. I guess you guys don't have these slides, but the surviving sepsis campaign says way before you ever start any vasopressors or IV drips that clamp those blood vessels down, you have to fluid resuscitate. You have to fluid resuscitate with tons of fluid. Do you guys remember from peds, fluid resuscitation? I think in peds it's usually 20 mLs per kilogram. But the new 2018 update for sepsis says we need to dump 30 mLs per kilogram into this patient way before we ever start dopamine, norepinephrine, or epinephrine. Blood flow versus blood pressure. Any questions on that? So let me explain some hemodynamic numbers real quick. Does anyone know what a central venous pressure is? Ever heard that term? CVP. Hint, hint, CVP. The central venous pressure is what I call preload. And all that is the amount of blood returning to the heart. The amount of blood returning to the heart, and the normal CVP is 0 to 8. So what we're essentially trying to do is measure blood pressure, but in the venous system. Remember, the venous system is very low pressure. The arterial system, which is over here, is very high pressure. I have put my phone on because I set my alarm for break time. And telemarketer. I'm going to have my son design an app that just erases the phone part of the phone. Wouldn't that be awesome? Because it's really an obsolete technology. I mean, how many people actually answer their phone anymore? I was shocked to find out I had a phone app on my phone. It's crazy. Anyway, sorry, I'm so sorry about the telemarketer's call. So normal CVP, the pressure of the fluid running back into the heart, 0 to 8. On the other side, we have a number which is called systemic vascular resistance, what I like to call afterload. Afterload is how tightly clamped down your aorta and all of your arteries are. How tightly clamped down everything is. And you don't need to know normals of SVR for the exam, I doubt, because you would if you ever take your CCRN exam, but the normals are 900 to 1400, and it's measured in weird dimes per second per centimeter, so it's not even, it's a very confusing number. But basically it's just telling you how clamped down those arteries are. So if those arteries are completely clamped down, what does that mean for how hard your heart has to work?
It has to work very hard to perfuse.
Yes, it has to work very hard. And so a third measure that we talk about in hemodynamics, we've got preload, we have afterload, and then contractility. how hard the heart is beating. And there's two numbers associated with contractility. One is stroke volume, which is how many milliliters your heart kicks out with each beat. Every time your heart beats, how many milliliters does it kick out? Does anyone know? Like, what would be a rough guess? How much do you think? If we had, how many milliliters is this thing? This is 800 milliliters. Your heart kicks out, on average, for the average person, 70 milliliters per heartbeat. And you can feel those 70 milliliters when you check your pulse. 70 mLs per heartbeat. And then another number that we talk about a lot is ejection fraction. Ejection fraction, and we'll say that 60%, really anything between 50 and 70 is considered normal. We get concerned in hemodynamics if the ejection fraction is less than 50%.
What's the ejection fraction?
That's a percentage of how much of the blood in your left ventricle gets pumped out, because not all of it pumps out with each heartbeat. So if your stroke volume is normally 70, that means you probably have 100 mL sitting in here. 100 mL, but only 70 or 70% kick out with each heartbeat. That's called the ejection fraction. What percentage of it kicks out? And that's how doctors decide between systolic heart failure and diastolic heart failure. That's the one reason we like to know that number. That's super confusing, so I'm going to erase that. Forget I said anything. Ejection fraction. Because I do want you to know another number called cardiac output. Cardiac output is simply how much blood is pumping out over time. So what we're doing is multiplying this number, stroke volume, times your heart rate. And that's what the word cardiac output is referring to. Kind of means the same thing as stroke volume, how much blood you're pumping out, but we just multiply it so that we can figure out per minute. Over the course of a minute, how much blood are you pumping out? If your heart is beating 70 times per minute, well then you've got a stroke volume of 70 times 70. And that's your cardiac output. This changes greatly based on your physical size. So the average female is something like 5 liters as far as how much blood they're pumping out. Whereas like Shaquille O'Neal, just to even stay alive, he has to pump out twice that number per minute, and that's normal for him. Because those numbers vary so wildly, we tend to create a third number called cardiac index, which just takes this number and figures out how big you are. So we divide it by body surface area. How big are you? How big are you? And I don't think you'll need to know normals for the test, but the cardiac index normal would be like 2.5. to 4 or something in there. So we have 3 things that determine whether or not you're in shock and whether you're getting perfusion. We've got preload, contractility, and afterload. To break it down so that it makes sense, I think we could call contractility the pump. The pump. SVR is telling us about the pipes. And then what CVP is actually telling us, how much fluid you have. How much blood. And that's how we use it in clinical settings. I remember when I was an ICU nurse, this was in the year 2001. I was only an ICU nurse, hardcore, full-time for a year before I went to the ER because I got bored in ICU. It was like the exact same thing, this thing, the sepsis thing, over and over and over again. So what we used to do is play with stuff, which I think is a valuable skill. When you're a new nurse and you start on whatever unit you start on, get in the habit of playing with stuff. Play with equipment. Play with equipment. If a piece of equipment terrifies you, like the crash cart, for example, most units have a crash cart. I recommend playing with that crash cart at least once a week. I actually wrote that on my professional development goals my first year. I'm going to play with the crash cart once a week so that eventually I wasn't terrified of it. And then, because when you're in a code situation, it's always somebody yelling for something. Dr. McGann, I used to make fun of him. He'd always say, "Get that thing, get that thing." And he'd scream it, "Get that thing." And new nurses were like, "What thing?" So the more you play with equipment and look through the crash cart, the more you kind of know what thing he's talking about. Oh, you meant the suction. That was one time he wanted a yank hour. Get that thing. So play with your equipment. And one thing that we started doing is when we realized that we could measure pressures in any body organ, if we just had a simple device called a transducer. I just happen to have one here. If we just had a simple device that could change a mechanical pressure to an actual electrical number. That's all we're really doing. With all these fancy hemodynamic parameters, we're connecting a transducer, and a transducer looks like this, depending on what brand you have in your hospital. And so the very first thing we hooked it up to, just to see what kind of numbers we'd get, was we screwed this thing onto the end of a central line. Plug a transducer onto the end of a central line. Where does a central line end? Where's the tip of the central line? Whether it be a PICC line. It's in the low pressure system. This is called the vena cava right here. And so that's the low pressure side. The high pressure side is the aorta over here. And in general, we don't mess with the aorta as nurses. I will tell you, today we'll talk about some exceptions to that, like balloon pumps, intra-aortic balloon pump. But for the most part, every single patient in the hospital either has a PICC line or a central line, which starts either way down here in their arm or up in their chest. But the tip of it, for the most part, ends right here in the right atria. And you can read the X-ray report. It's kind of fascinating because the radiologist always reports exactly where the tip ends. PICC line tip is in the right atria, or the tip is 1 centimeter above the right atria. So then all we did is we hooked up a transducer to that central line, knowing that it's sitting right here, the tip, the opening, the hole at the end. And that gave us a number which came to be known as central venous pressure. So that's all that you're really measuring, is the blood pressure in that right atria. What that's telling us is how dehydrated this person is. How dehydrated. If the CVP is super, super low, this patient is very, very dehydrated. And so how low is too low? And what should we do to fix that? The normal numbers are 0 to 8, and I've hooked these up to people and gotten negative numbers. Negative numbers. Is that person too dry? Yes. They're so dehydrated, they're really not getting any blood return to their heart. And we see this in kids. And that's really one of the top 2 leading causes of death in children. Dehydration. We hook up a CVP to measure their blood pressure in their right atria, and they don't even have any. It could be 0. So for the sepsis resuscitation guidelines, how hydrated do they want these people? They want that CVP at least 8. The true protocol says 8 to 12. Other things that we hooked this up to, which I won't talk about, but just to let you know how fun it is to be a night shift ICU nurse when the managers are gone. We hooked this up to Foley catheters, which sounds crazy until the research caught up and we found out that most of our trauma patients have what's called intra-abdominal compartment syndrome. And by hooking up a transducer to that Foley, we were actually measuring their whole pressure in their belly, And that dramatically changed trauma outcomes. This has probably been 10 or 12 years ago where we started. Do you guys know what compartment syndrome is? Do you remember that?
Yeah.
You know what the treatment for that is? Like if you have compartment syndrome in your leg.
Sometimes a fasciotomy.
Yeah, fasciotomy, which is a real fancy way of saying, we just cut the holy heck out of this person. We're just going to take a razor blade and slice them all up. It's pretty gruesome, and I'm not a big fan. I'd rather not do. So in trauma, what we found out is we just started doing fasciotomies on people's bellies. And they would leave them open with the wound vac or just open to air for 3 weeks. And their survival rate went way up, simply from ICU nurses playing around with transducers and hooking them up to things they shouldn't have. Should not be doing that. So play with the equipment. I think it's a valuable skill. What happens if our CVP is way too high, though? What would that be telling us? Let's say this CVP is like 18 or something. It's actually not so much telling us about overhydration, even though that's what we call it, and the doctors will call it that. All it's really telling us, the heart's not beating effectively. Technically, the CVP is measuring the right side of the heart, so technically it would be called right-sided heart failure. But the number one cause of right-sided heart failure is left-sided heart failure. So if that CVP is sky high, what symptoms would you notice as a nurse? All the symptoms of heart failure, really.
Right, but would they have the right-sided symptoms too then?
The CVP is primarily measuring the right side, so we're primarily thinking right-sided heart failure.
So edema.
So edema, that's huge, definitely. And jugular venous distension. So those two symptoms are really specific to right-sided heart failure. There's another number that's more specific to left-sided heart failure that we will talk about a little bit later. But that number is called the wedge, or pulmonary capillary wedge pressure. So you'll see it sometimes on test questions, PCWP. So the CVP is measuring the right side, the wedge pressure is measuring the left side. So what do we want that map to be? And the sepsis guidelines have exact numbers of what they want the map to be. Because there's two things sitting down here, your retroperitoneal space, your heart, pumping blood out of your aorta down to your renal arteries. And to keep that blood pumping, your MAP has to be 65. Memorize that number. That's the sepsis guideline for fluid resuscitation. Your MAP has to be greater than or equal to 65. But what's another vital sign that we could measure that would tell us whether or not the kidneys are getting enough blood? It's a vitally important vital sign, and we don't think to measure it unless you're in the ICU, where you have a Foley bag with a urometer on it, and that's urine output. This is 0.5 milliliters per kilogram per hour. It has to be greater than that. When I worked in the ICU, we had a trauma surgeon, and because I'm recording this, I won't use the word asshole to describe him. But when you called him, he was very rude, unpleasant to work with. And you could do all the hemodynamic monitoring in the world, because you know when you call a doctor, you have to have your vital signs in front of you, right? And so the ICU nurses would work and work and work and write down all 150 vital signs that they had been obtaining every 5 minutes on this patient. Call the trauma surgeon, and the only vital sign he wanted to know, the only thing he cared about, he didn't care about CVP, he didn't care about wedge, he didn't care about MAP, urine output. So I called him. My patient's crashing. I'm concerned. Here's the vitals. And he cut me short. What was the urine output for the last hour? That's all he wanted to know. And when I told him, he's like, Okay, call me back in another hour if that changes. Click. And the science actually seems to be saying that's really all we need to know. All these fancy interventions that we've invented over the years to give us all kinds of fancy numbers, and urine output tells us the whole story. So on the second page of Josh's Guide to Hemodynamics, this is all you really need to know. Is your patient mentating, which means are they thinking clearly? Are they thinking clearly? Are they ventilating, which means are they breathing okay? If they're perfectly alert and appropriate and their breathing is fine, then the next question, are they urinating? And those are all you really need to know at the bedside. If they meet all three of those criteria, this patient is probably not a critical care patient and don't need to be in the ICU. So one other number I just want to introduce you to, your heart is pumping blood up into your brain, and we call that cerebral blood flow. Cerebral blood flow. And the number that we use is called cerebral perfusion pressure. And that number is simply your mean arterial pressure minus your intracranial pressure. The intracranial pressure is kind of pressing down, and your mean arterial pressure is the blood flow up. So your ICP and normal is 10. Intracranial pressure is resisting blood flow into your brain. And so let's say the MAP is 65. Your cerebral perfusion pressure is 65 minus 10. And if that starts getting too low, your patient is no longer mentating. They're not thinking clearly. Most trauma guidelines want this number to be greater than or equal to 70. That's for most trauma resuscitation guidelines. But here's a $1 million question. If we take our transducer, we've already figured out we can connect it to anything to measure a pressure in that something. We can measure the pressure in the bladder. We can measure the pressure in the right atria. How in the world are we getting this number? Intracranial pressure. Any idea?
There's a pressure monitor for that too, isn't there?
A monitor for that? There is, and it's a special kind of monitor. We call it a bolt, which is where the neurosurgeon, who are really just like Bob the Builders, they're really construction workers, they take a drill and they drill a hole in your skull and screw a bolt in that's hollow so that we can hook this up to it. That's literally how we obtain intracranial pressure. This is not a nursing function. Don't be drilling holes in people's skull. You are practicing outside your scope.